Welcome to episode 6 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and bridge academic research to the clinical setting. In today's episode, Perttu Riipinen joins us from across the pond in Finland. Perttu is a young practicing musculoskeletal clinician and a recent graduate from Chiropractic College in Wales. He's been involved with the Back to Roots group and is one of the young, bright minds in the musculoskeletal field. We get into some good discussions on his clinical approach, touch on a little bit of myth busting, the importance of communication in the clinical setting, and also hear some advice directed towards other young clinicians and students in the MSK field. Be sure to visit us at www.thearmy.ca for more resources and information, and we hope you enjoyed today's episode. Okay, that's on me. So why don't we just start things off here, too, by you kind of telling us about your general background, how you got involved into chiropractic education in the profession, and then sort of where you're at, like how you got to the point where you're at now, which is quite different than probably when you first entered, right? So why don't you give us a little bit about that?
Yeah, sure. So I think quite different to many people in my class. How I got into the chiropractic education was basically not knowing much about the profession. It was based on shadowing 1 day worth of a chiropractor in his private clinic treating patients. And that was the only thing that I got from it based on what I observed. But how I got into that position was, I'd say throughout my years of playing football. Do you guys call it football or soccer? By the way, is that
both? Either.
Both. Okay, yeah. Either. So yeah, played football, and I would consider myself, I guess, fairly talented, and I had a desire to become a professional football player, but experienced some, one day, an onset of low back pain when I was 15 years of age, which persisted for over 2 years. And that's how I got into the trap of trying to find solutions and answers to my own back pain, which then I sought care from many different healthcare professionals and had various different types of treatments and never really found the answer, and which is also probably what is motivating me these days, because I just got more and more frustrated because I was told all the possible narratives that you could imagine for the cause of my pain. So I think that was the reason why I went into the profession. But before that, I studied to become a sports massage therapist, and that was really because I got interested in medical school. But I was like, I have probably no shot in getting into the medical school, because I was at a point between my 15 when I had the episode of back pain for 2 years. I was 15 at a time till 17. So I was at a high school as well, and in Finland, if you really want to get into medical school, you probably have to have really good grades from high school to be able to take in, seriously for the application. And I got quite depressed at a time because that, if you want to call it injury or pain at the time, it took me away from playing football for that, over 2 years. So I was also at a high school where there was like a football academy, and I couldn't play at the time. So I got quite depressed and just didn't want to focus on any of my studies. All day long, I played Xbox, playing Call of Duty. So that's probably took me in a position where I finally actually graduated from high school, that my grades would not be good enough to apply for medical school. So I think the person that I got most help from was actually a sports massage therapist. And that was probably the reason, because he was just such a nice guy. And he told me that if I don't have any sort of direction to go, and I would have 1 year of studying to get at least some form of degree or profession, and have a nice year to meet up with good mates and study in a nice city, he would recommend to go there. So I did. That took a total of 1 year. Then I actually practiced as a self-employed massage therapist for 1 year. But at the time, I was still having back pain myself, because that initial between 15 years and 17 years of age, after that, there was maybe 2 years of pain-free duration, I would say. But then I started developing back pain again. So at that time, I still had back pain myself, and I was still searching for these answers. But and I was supposed to help people with back pain, and they came on complaining and pointing in the area of their lower back, and I would just have no idea what it was causing, because the education in the massage therapy school was literally crash course of anatomy and physiology, and then all you did was just hands-on treatment. So I would just get the people to lie on their table and give them a rub and hope that for some it helped, and others it didn't, but that was all I knew. So I really wanted to get a better understanding of why do we experience pain, and where does it come from, based on my own experiences, because it was quite debilitating at the time, and it really had an impact on my life, taking away my kind of dream to be a professional football player. So how did chiropractic came into the picture was that my mom had some episodes of back pain as well, and she was recommended to go see a local chiropractor. And after a couple of visits, she got quite good relief from the treatment. And I thought, like, I've had this pain for now years, and she has it for a couple of weeks, goes to see a chiropractor, feels good about it. Like, that doesn't seem fair. So I'd like to know a bit more what this profession is all about. And yep, send him a message if I can come to shadow him, and was fortunate enough that he was very happy about it. And he basically just told me that after the one day, that if I'd be interested in the profession, he would help me get me to the school, and he'd write a recommendation, he'd give me guidance on how to apply and all of that stuff. And what I at the time saw was very impressive, and I thought that this is literally people come in with back pain, you look at their difficulties walking or doing any sort of movements, and then after a couple of manipulations, people are pain-free. That was my thought. Obviously it's a lot different at this time, but that's kind of what I saw at the time, and I decided to apply into school. And I kind of thought it was, again, a little bit of you study a little bit further anatomy and physiology, but then all you do is track backs from first year on. But I was quite surprised actually by the amount of content when I finally entered the school. It was, based on what you guys know as well, the amount of time you study in anatomy and physiology, neurology, general diagnosis, radiology, it was just like, what blew my mind. Like, why do I need all of this? But so yeah, fast forward 4 years, things have changed. I don't really see it anymore. As you go to the office as a chiropractor, get one manipulation and your pain is gone. But that came into the realization more when I actually entered in my final year as an intern at the outpatient clinic, based on with you guys probably going through the same majority. I'd say probably 95% of the time, the education is very much around the biomedical model of pain. And I got to experience it myself, especially interacting with the floor tutors that were guiding your education. Was I at that time should have had 3 years in the chiro school, 1 year in the sports massage therapy school, and 1 year of practice myself. So 5 years experience on palpation, and I should be able to palpate these joints. And here comes a floor tutor and tells me it's C12 on the left, and you should just manipulate that, and then it's T3-4 or whatever. I was like, how do you tell that? Like, I can't. And that took me down into the I guess endless rabbit hole of discovering a bit about the research. What does he actually say about, and end up doing my thesis about the reliability of palpation methods and the specificity of manual therapy. And it really hit me quite hard at the time when I noticed that a lot of the things that I was taught was outdated, and things don't go quite as straightforward and linearly as it was throughout the education. So that then drew me to read a lot more outside the literature and experimenting more with the with the I guess biopsychosocial model of pain, and the pain, thrown further into the rabbit hole of the pain science. And I think that has shaped me where I'm at now, 1 year in practice almost. So while that hit me, the hard realization that things are not as they've been taught to me, I think that's when the uncertainty hit me really bad. Like, I've studied all these years into a profession which doesn't seem to work the way it should. And like, how am I supposed to help these patients now coming to see me? Because that was what I saw, and it doesn't work kind of this way. That interactions with the healthcare and managing pain is so much more complicated and complex than that. So it was really difficult at the time, but sooner I realized that it's actually quite liberating as well, because I was like, thought in my head, having these interactions with tutors of like, I need to go all of these different technique courses. Like, I have to learn all of the manipulations, all of the palpation methods, you name it. And that was really big frustration to me. it's like that I need to go endless amounts of CPDs afterwards. But that coming to the realization that things actually don't work that way was really liberating to me. So sooner the uncertainty hit me, but now it was like a empowerment and starting to feel actually more confident on what I can do with people. It's a lot more, I'm not sure if you could call it freestyle, but putting it into the into the patient and their experiences rather than following a certain type of script that it seemed to be in the clinic. So now it's been in practice through just trialing and erroring, adopting implementing the patient-centered or biopsychosocial model into practice, and lots of errors and mistakes and self-reflections. I think now I'm at the point where I'm fairly happy how things are going, but obviously it's never is complete because the science will evolve all the time. But seemingly at this moment in time, I'm quite happy how things are going. But it's been a really big learning curve with a lot of frustrations and almost wanted to quit and give up on this profession, but still going strong. So I guess that was a short summary of how I got into the profession and how things are now.
When you started getting into some of these other resources, when you're becoming uncertain and stuff, who were some of the names that you really kind of, I guess, related with, like some of their content, and what kind of started pushing you to look more and more? So like for myself, when I was introduced to, a guy like Peter O'Sullivan, that really got the snowball effect going. So who are some of the folks that really kind of helped you develop to where you are at this point?
Yeah, good question. I think it is, I can't really name a specific persons, but I'd say similar to all of us, the likes of Peter O'Sullivan, Kieran O'Sullivan, JP Canero, Samantha Bunsley, what they're doing in their the cognitive functional therapy group, and how similarly names like Bendalo, which is now a joke with a couple of other mates. We always, if we have a discussion, there has to be always one Bendalo reference. Guys does so much great work. He always gets reference. And then obviously, but that time it was more around the literature on the manual methods and specificity of palpation, which drove me into the seeing like, okay, the biomedical model and biomechanical model doesn't really seem to work. So where do we go from here? And I think that was the starting point. And then it turned into these names. And I think also I had to give a shout out to Paul McCambridge and Luke Davies from Back to Roots, because they came to have a lecture to us on, that time I had been on the final year for about 6 months or so. So they came on January 2019, and we started the final year in June 2018. So that was quite like a tipping point that I've been finishing my my dissertation, and started to get into the literature of pain science. And I was having discussions with my colleagues, and they just seemed to, we got into a bit of a heated arguments and debates about this. And I kind of fell a little bit of a lone wolf, I'd say, with a couple of friends of mine who I used to live with. So I was in this little biopsychosocial bubble at the time, but they came to have a lecture on us, and the first lecture was on I think it was titled Pain Science, and somewhere around that, and it was funny enough, there was a lot of resistance to that class. After the first class, I think the dropout rate was from 60 students to about 20 or something, because it was just too much to hit them throughout what they've learned and what we've learned in the school. But to me, that was like, okay, finally someone talks this same language. So that was like a big tipping point, and obviously getting to talk with these guys was reinforming what I've learned at the time. And it was like you said, David, it's like a snowball effect that it keeps on going, and you get to read more of the literature, get more names around here. But I think probably at this given time, most influenced by the cognitive functional therapy research group with Samantha Bunsley and JP Canero and Peter O'Sullivan. It seems to make a lot of sense to me based on what we understand at the moment.
Yeah, and that's like, those people are all brilliant. Like, their work is always it's like always very insightful and just like very well done. It just presents that creative opportunity, right? Like, you're not confined to, I feel this, I have to do this. It lets you be creative and put the person at the center of that equation, right? But one thing you mentioned is the Back to Roots guys. And that's how I first ever found out about any of your content, Perttu, was through the B2R guys. I remember seeing some Luke and some Paul stuff. So can you tell us a little bit more about Back to Roots and a little bit more about like what that kind of model or what that framework is that they really try to push forward and what you really try to push forward through it?
Yeah, sure. So that is like, at the time it was so different, because like I said, it was, I was seeing some of the content that they showed through, slides, because I was thinking the same thing, that it's just all seems so linear the way we were being taught. You just find out what's quote unquote the pain generator, palpate it in which direction it is, not moving or moving too much, and you either stabilize or you just, quote unquote release it. It just sounds so simple and logical, but things get, it just doesn't seem to be this way. Some people respond really, maybe responding well to that, but others just, you get a completely different response. But that drove me into the bit of the difficulty, that I have to just keep getting better at pattern recognition and being, this linear type of approach. But then being, introduced to Back to Roots at that time was like, okay, this seems that you have a lot more freedom, that you can focus on the person that eventually is, like I said, just now there is more liberating, gives you a lot more opportunities. But yeah, so with the Back to Roots, what I think hit me most at that time was seeing the kind of creativity around movement, and because it was so so different, and that was what I got to. They came to, I think they have a total of like 4 lectures with us and a couple of the workshops. So I got I can imagine the people who left after the couple of lectures, because it was just so much at the time. By getting to know them more, it was just probably at that time one of the people who to implement the current evidence-based into one nice treatment model. So, but how I would summarize it is more of a tricky part. I guess is how Luke liked to describe it, is like evidence-based holistic healthcare, in implementing, I guess, a lot of the concepts on the patient-centered model of care, and focused on exercise prescription and active care models, which was at the time also, that was what got me into attract with their work, was because I felt so limited in my ability to prescribe exercise. Because it was, the traditional type of stabilization, core stability work that you learn, big threes from McGill and all that. So I was like, after I'm graduating, I can barely just prescribe these 3 exercises to every single client with back pain, and that was so different, seeing them using a lot more this non-linear type of approach, using various constraints. Now, this is just so novel and new, but it seems to make a lot more sense, because I've tried these types of models in the past with my own back pain, and it just doesn't seem to make things any better. So that was quite motivating. But yeah, that was how I would probably describe it in a sense. And I've throughout the early this year, I've gone through a mentoring program with them, and I think the biggest tips and takeaways from that is indeed that creativity in exercise prescription, and exercise can be just as trying to get the individual to tell you what their fearful activities are, or what they're not currently doing, and try to find ways to get to that exact activity in a different way, and showing how adaptable the human body can be. And there's loads of different rooms for a variety of movement, and that could be as simple as the exercise prescription and working your way through that. So I think that's really how it's shaped my exercise prescription currently, and using the concepts of what you've probably seen in some of those videos, the playful approach, which is nice as well, because it can take away some of the focus of the quote unquote exercise, because some people may be fearful of just a word, or thinking that I've tried physio in the past and they gave me exercise and it didn't work, so you just frame it completely differently. And I think it's a nice way to confront some people with their fears, to have some rules in a game and play around, and maybe, do that in front of a mirror or film it with your phone and then show them afterwards, like, look, all this capacity of movement that you were able to do based on what you told me that you weren't. And then they get to, summarize it back to you that, hey, actually that felt quite nice. I don't really see why that is, because last time I tried to do that, it hurt a lot. And is what I think what Back to Roots guys have been hugely influenced has been Louis Gifford, that idea of restoring that thoughtless, fearless, and relaxed type of movement. And I think the application of the clinical play can be a really useful strategy in that, and it makes it fun for the patient and yourself as well. But you got to be creative, because some people may not understand why, or if, first of all, when people who I discussed in my class, for example, about the idea of clinical play, it's just like, well, you're just playing around with the patient, you're taking them seriously, you're just doing some I don't know, random dance moves. But it's definitely as it may come around to some people, but there's definitely a lot more nuance in that concept.
Yeah, I think that's like one of the coolest things that you and the other B2R guys do, is that idea of clinical play. And I know that all of us have talked about that before, because one of the big fights that we see for whatever reason between physio, chiro, osteopathy, whatever MSK group you want to talk about, is this idea that manual therapy sort of works and exercise sort of works. Like, everything sort of works the same amount if you want to look at just looking at back pain, in pain in general. But with that clinical play thing, that's what people are trying to argue for, is that it doesn't need to be exercise, like you just said, right? Like, the idea that exercise gets someone better. Exercise can be rolling a ball back and forth to each other, right? They can be bending over to move stuff in a different way that they haven't done before, and you can kind of play with it, like exactly what you were saying. And so what that kind of leads me to is what you were saying about, like, when we talk about evidence-based. So like, evidence-based stuff can be like, for back pain, for example, it's like reassurance, advice, and then some exercise is considered kind of that first line. But this is where we get that argument. It's like, what is exercise? And it can be play, like you said. So what do you think is kind of, and this is a long-winded way, but what do you think is the difference between when people say like, oh, I'm evidence-based, or they're actually using the best available evidence that can help someone? Because anything can be evidence-based. You can find a paper that fits your clinical experience and then use it. That's not being evidence-based, right? That's failing to take away or failing to implement actual evidence. So what do you think about that when someone says that? Do you think that evidence-based actually is what it sounds like anymore, or have we kind of lost our direction on that a little bit?
Yeah, that's a fantastic question. It's not an easy one to answer. I've been thinking the same thing. Is like, what is evidence-based practice? It's so easy. Some people say like, I use education. I do manual therapy and give exercise. So I'm an evidence-based practitioner. But I think many people can say that, and in fact, really trying to use guideline based approaches to care. But I think one of the big struggles that, for example, Paul Cambridge from Back to Roots has been talking many times, is the actual implementation of that, and how does it look in practice. Same with the whole biopsychosocial model. People can talk about it, but in fact, often still revert to very biomedically or biomechanically based approaches. So actually trying to implement that is really challenging. But to answer your question, like, what is evidence-based practice? Like, how does it look like, and how should it look like? That's a really good question. I'm not 100% sure how to answer to that question. But for me, I think what the most of the guidelines are suggesting, for example, if we summarize the paper from Lin in 2019, probably the first recommendations of the musculoskeletal guideline is that it should be patient-centered, and that's how it should. But that, again, like, what does that actually mean? It's a really good question to me. And again, how you frame exercise in a patient-centered manner, or is indeed what we just discussed, whether that was play or some form of pushing a ball and throwing that to each other, or lifting weights, or doing whatever stability exercise, you name it, is based on what they actually require, demand in their life. What is it that because I don't think, same with my perspective with back pain, that doing stability exercises was like, I remember the time I was having these old, blood pressure cuff machines in my back of my lumbar spine. I was lying there and I was looking at the cuff and I was trying to brace or bring my tummy in to quote unquote activate the TVA, and look that it was staying in that exact line. I was looking at the side of the pitch watching my teammates playing football, and I was there lying on the side of the field doing those exercises. I'm like, these are not taking me anywhere close to my goal, but obviously I didn't know that at the time. So now I think it's more about, if we look at say manual therapy or even exercise, it can be very clinician directed or driven process. So giving exercise in favor of manual therapy doesn't necessarily mean that you're doing such a great job and being more evidence based. It's just like, okay, all the evidence suggesting that we should move towards active care and exercise, but you're still prescribing very arbitrary exercise to someone that doesn't align with their goals. So I think that is much better. So how I've tried to approach it in this direction is indeed listen to the patient's story and their narrative and build the prescription around their narratives is indeed, and find ways to move in whatever position or movement that they are maybe fearful of or worried or anxious or having trouble, and they would need that in their activities of daily living, and find solutions around that, whether that was through clinical play or resistance training or whatever. I'm quite happy to do whichever. I'm not sure if that answered your question, but I don't know how to answer that. It's a difficult one.
No, that's like, I'll let you go in a second, Elliot. That's perfect. That's the discussion that I think us four have a lot of the time, is like evidence. We've lost the direction of evidence-based. And if you go back to what Sackett originally said about it, like, we're not following that direction at all. It's the same way we don't follow the biopsychosocial way method that Engel described 30 something years ago, right? We've kind of butchered that original concept, and we've lost its kind of direction. But I think people like you and people like you said, Paul, and the guys at B2R are doing a great job of making that focus again, taking that original idea and applying it to the people in front of you. And like you said, I love that. I think exercise can be anything. I know all of us here are huge believers in that minimum effective dose. Like, what can we apply to a person that matters to them? That's step one. And then step two, some people don't like to exercise, but we know that aerobic exercise is good for you. We know that resistance training is good for you. So how can we package that to someone that matters? Like, you know what I mean? Like, my dad doesn't love to exercise, but 15 minutes of resistance training for him is probably good enough a couple times a week. So it's finding that middle ground. And now I'll stop talking so you can, Elliot.
Well, it was just the way that you brought up how things are often very clinician driven. Is back in 2007 with that Finch paper, looking at shifting away from the idea of evidence-based practice being the three pillars of evidence-based practice, and moving towards the funnel. I think the three pillars traditionally were the relevant research, the clinician's experience, and then patient expectation, and how they're all of equal value. And that can often draw people away, because if you have the research, let's say some sort of manual therapy or some sort of passive intervention like ultrasound or something like that for low back pain, we know from the research it's nothing. It does nothing beyond placebo. And the research says that very clearly, that it's just not that useful. There's so many things better than that. And then a clinician may say, well, I've used it in the past and I find that it's quite effective. So that's my experience. And the patient says, well, I want to try ultrasound because I don't want to exercise, or I think exercise is harmful, or moving is painful, so it must be bad. So I just want to lie on the table and get ultrasound. So with that, it's like, well, let's use ultrasound, right? Because even though the research says it doesn't work, I've seen it work in the past and the patient wants it. So this brings up the idea of, instead of having the evidence-based pillars, the evidence-based funnel, where we've got the research, here's what works better. And then we can evaluate that, evaluate the research based off of our experience. Okay, well, in my experience, patients who are presenting with back pain of this character may feel better with this type of manual therapy, which is no better than this type of manual therapy, so long as it's all based around getting them active and then focusing on the patient. right? So the idea of putting things forward to the patient where patient values and clinical experience, they are important, but that's only when those expectations or what the patient or what the clinician wants is no better than what they need, which is a great line that I heard from a certain friend of mine.
Oh, that was me.
Oh, okay, that was Ben.
Oh,
Okay.
yeah. Like, sorry, I'm gonna hijack that because I want to frame what you just said, because I loved everything, Elliot. I'm gonna frame it to the exact question that I want to ask from your thing. So you were good talking, but I'm more important. So when someone comes in and we want to offer them, and they have an idea of what they want, Perttu, like they have an idea of what their expectation of a treatment is. If we have two treatments that will work, let's say for this patient's needs, and they're of equal value, that's when personally I think we think, okay, that's when the patient values really matter, right? If we have two things of equal value and the patient really believes in one, that's a great time to use that treatment. But if a patient comes in and they really want something that has no clinical efficacy, if we want to use those terms, and you know that they probably should try something else or do something else, how do you present that to them? So if someone comes to you and they say they really want massage, but you know that for this person, they need to be a little bit more active. How do you bridge that gap? Because you know which one is probably going to work a little bit better, but they really want the other thing. How do you work between that concept?
Yeah, that's another fantastic question. I think that's gone through loads of failures already, of me trying to be too aggressive in saying these things like, okay, we probably should not be doing that, and this one I think with the more research behind me backing up, we should be doing this, and you just totally invalidate the person and their what they want, and odds are that they're probably not going to come back to you and they're going to go to someone else who will provide that. So it's a really difficult a place to navigate through, and so I've had to try to do that gradually based on, first of all, asking the questions of what is it that you want this treatment, and often like persons coming to see me is not because they want massage therapy, it's because they want a spinal manipulation, and I was like, what happens when you get spinal manipulation done to you? Why is it that you need it? And often it comes back to their beliefs about something is out of position, or something doesn't move in their body, or needs to be relocated or done, whatever, and that's an opportunity for me to then, it's like, okay, well, let's have a look, and let me do a physical examination and evaluate your concerns and why you need this treatment. So that's a really good opportunity to tell them that nothing is inherently wrong in the spine. There's nothing out, nothing needs to be put back in place. So therefore, this reasoning to your belief why you need the treatment is, I don't think it's good, and we don't need to do that. There's no reason to put anything back, because everything seems normal in here. And that is like, if you come into the realization and like, okay, well, the previous therapist may have said that, and they may have said this, but then I also come into asking that question. So what makes sense to you? Like, do you think, say, if your pelvis was out of position, why some other days you're feeling totally fine and you don't experience any pain? Or why you went on a week on a holiday and you felt great and you didn't experience pain? What happened there? Was the pelvis not, was that aligned then, or was it still out? It's trying to create a little bit of discrepancy between their actual, beliefs about their pain and what's causing it. And then that may have given you an opportunity for asking permission to try something else. So it's like, okay, like based on my what I've examined you, my evaluation, but based on my best understanding, there's nothing to be concerned of here. What is your concern? So there's no need for this treatment. You could, like, would you be happy to try something else? And if you brought up I don't want to be too pain focused with the individuals, but I can say that there's some research evidence based on that this sort of active interventions are really good for managing your pain. And if you've had a long history of passive treatments, if you think that the treatments have been successful, why do you think you're still experiencing pain? So trying to get them understand that there may be something else going on, and they would probably need a bit more active care to help to move them forward closer to their goals. So I think that's quite important, but it's really difficult to try to do it gradually, so you don't go into quick attack, because you can feel that they don't hear you, or that you're invalidating their experience. But still, it broke to my mind one female patient that we had a really long discussion at the beginning of the session, and we basically got her, because she had a problem with back pain doing squats and deadlifts in the gym, and she had a past history of previous passive therapies. So my focus obviously was to try to get her exposed to that movement again and find ways to try it. And she was still like hoping and wanting to get the spinal manipulation. She said that's like giving her some good results in the past, what she believed on. And I tried my best. What I always do is reframe it away from any pathoanatomical biomechanical beliefs. So just being honest, like, this may help temporary for your pain, but that's pretty much what we know about it. So did that at the very end of the treatment and got her back under the bar, tried again, still feeling everything good. And after an hour and a half of mostly discussion, mostly active care, and maybe 1 to 2 minutes of spinal manipulative therapy, she reflected back on the success of that actual visit and what she thinks was the turning point why she felt better. Guess what? It was the manual therapy. So that's the difficulty, that you may even if you are putting in some form of passive therapy treatment in there, where your approach would be more guided towards active therapy and exercise, it is so easy for the patient, based on their beliefs, to think it was the small 1% of that treatment where you did a little bit of passive care that was what got them better. And you may have done a great job in educating them about pain and getting them active, but that's the thing that they will remember. and if it feels great, which it often does, they will keep wanting that. Like you said before, they want to get that exact same treatment. If you don't want to provide that, they may be dissatisfied with the care. So I think it's a really fine line and delicate area to try and approach, especially if they had a long history of passive treatments. The harder it is. But we obviously will try our best to try and navigate through that difficult space, but it will take time for sure. And I think the best way to get to that is not just by education, but is actually going through elicit behavior change and go through behavioral learning, because you may try to get someone educated well on a topic, and they may tell you that this is what they believe, but actually their behavior and action will tell you different things, and they may revert back to their own beliefs. And I think that was what the recent paper, the beliefs about body and the pain from Peter O'Sullivan, Samantha Bunsley, and JP Canero was saying that people still hold implicit biases towards what they may actually not say against, or they were like, okay, even clinicians as well say that they understand something and totally different, but their behavior doesn't, or it contradicts what they believe.
Well, you started out with taking very much a motivational interviewing approach to it, where you're not just rudely data dumping on them and just saying, oh, well, you think this helps, but because the research says otherwise, you're just wrong. Like, you're absolutely wrong. So here's what the research says. We're not going to do that. But instead, you guide them towards the actual you guide them to it themselves, rather than you just telling them. So, well, why do you think that this is out? Why do you think that on good days when you're on vacation, it doesn't feel so bad? And then that's pretty good.
Yeah, because I quickly on that point, I think I've definitely been there at a position where I've had, after hearing their history, after the subjective interview, I've just straight gone to like, okay, this is what we understand about pain. It's all about all these different things, and they're just looking at you eyes glazed for like half an hour, and you wonder then after that treatment why they never came back to you, why they're not responding to your calls or your text messages or emails or whatever. So I've been at that point where I've gone way too quickly on there, because I think this was what Jared Hall said on one of the podcasts I heard. That was a brilliant point he made, that it's took us as clinicians for like 5 years or more to learn or where we are now, our current understanding of pain science. And it has started with basic anatomy and physiology, and it's gradually progressed to the point where we are now. But some of the patients may hear this for the first ever time. So you can imagine it's taken us that long, how the patients will respond to that. And we know how strong influence these, cultural beliefs and family and friends and all that will impact on them. And it may be, and most of the time, I only can recall a couple of, patients who would say that in the first visit that, hey, that actually makes sense, or I totally get this. Most of the time, it's just completely new information. So it's a bit of a journey to try to guide them through. And I think that can be a very, great way to reflect more back on them and ask them actually what is it what they believe about it. I think those questions, more open-ended questions, can be very, very useful, and try to create a little bit of a discrepancy from their narrative on based on what they are believing and what they're doing. Also, again, learn from Jared Hall is to ask permissions, so you're not just vomiting your knowledge on them and try to think that you sound super smart, and because that doesn't help in the long run. I've already seen it myself, and with very little clinical experience.
So quick question for you. I mean, I'm gonna probably go on a little rant beforehand, but I just wanted to first say I really like how you use certain words like permission. I ask permission for the patient to try to build that relationship, instead of a lot of clinicians will say like, oh, I told my patient to do this, they didn't follow through. And you get that feeling of they failed you. We've talked about this a few times, versus this is a partnership. I need to find something that works for you. You seem to use a lot of, I'll use the words backward design. I find out what they want to do, and then we work backwards from there. I think that's an amazing approach, versus this is what I do. Let's work forward and see where you end up, because this is what's worked for me and what I'm comfortable with as a clinician. So I just really like that. I just wanted to say that first of all. My question more relates to, we have evidence-based, and you seem to have mastered your craft to a large degree. I know you say you're learning and stuff, but from my perspective, at least, you seem to be very elegant with how you approach things. That being said, I don't know if you're aware of the work with Dr. Amendolia. He does a lot of work with spinal stenosis patients, but he's extremely evidence-based. He does research on his exercise protocols. He's a PhD, he works in the hospital setting, so maybe a little bit of a different population he works with. That being said, he has a hyper-rigid program that he has patients follow through with. Each week they get additional exercises. I won't go into the details. They're there because they need him. And therefore every week it gets intensified, and it's not individualized towards the patients. It's more so this is my program, and it gets results, and it's very standard in what we know, like increase repetitions, increase the amount of volume. I'm really wondering how you approach progressive overload with such a creative approach. Like, how do you end up taking these patients from, yes, we're going to look at this little thing, and then we're going to start to build up, when you have so much flexibility? So I was just wondering if you have any underlying principles you kind of use that you're trying to build them up from.
Yeah, fantastic question again. What you said in the first was that trying to not be as your clinician or practitioner driven, and put the patient into the driver's seat. But that can be sometimes, again, difficult, because they are expecting, especially they're coming to see you with an authority, say that you are a chiropractor, and their beliefs about what's going on, and what they have a firm belief what you're actually going to do to them. And if you then flip it back to them and ask very first question, which is actually a very important question I've learned to start asking more frequently, and obviously now do with every single patient, is actually very end of their subjective history. Ask what is that they want out of this session, what is their goals, what really brings them there. They may say initially that pain is what drives them, or is what they are coming there for, but that may be stopping from doing something, or is causing distress in their life. So if it's just focus on the pain, it's so easy to get into that, clinician-centered approach, like, oh, I got all these tools to manage your pain, but that not maybe anything to do with their goals. Again, so it's a difficult one to ask, but certainly I think very important, because I think the patient will get a lot more value out of that, rather than going to say like, yeah, they did a bunch of these things to me, and I feel quite good, because we know that many things give temporary relief. But rather than saying that, hey, actually they listened to my concerns and my worries, and they were really interested in what I wanted, and they gave all these tips and tools for me that I can do in my own time. Because I think often it is our clinicians' expectations that the patients really just want to buy a mechanical explanation and a diagnosis and into this diagnosis, treat cure pathway. If you actually ask more open-ended questions from the patient, is they just want to know better what's causing the pain, and if there's something that we could collectively do. But don't get me wrong, there's still, obviously there are people who have these preconceived notions of what's going to happen when they enter the room of a chiropractor. Before you even shake their hand, they're pulling their shirt off and lying on the bench. So more often than not, I find actually is that they're just looking for better answers. But yeah, so to your question, again, it really depends. I think same with you guys. I have a bias towards resistance training, but that may be, even if that's again what I would want them to do, but it may be what they actually want as a person. But I still find it very useful tool at some point during their management plan. But first of all, graduated approach through, say, use of like clinical play could be just as simple as getting someone to do a little bit of spinal flexion, whether that was in a seated position, and progress to, say, standing position, and then progress that to closer to the floor, or add some rotation into that. So there's so many different things that you can use in a simple play or a game with different constraints. So you can add them standing on a single leg or in two legs, or knees straight or knees bent, to get a little bit more motion through some areas of the back or their spine, wherever they may be a bit sensitive or fearful of moving or tensing up or guarding. So that will help. And sometimes it may be only that what the person needs is not a long-term plan, but it may be just a little bit of a conceptualization of pain, address their concerns and fears, get them moving in a more relaxed manner, and then put that into their context of what they need in activities of daily living, and show that they are in fact capable and able to do that, and get them encouraged, and they may be good to go with a couple of follow-up visits and see how they're doing. But I tend to use when it starts to say have a more of a longer journey that you feel like that the person needs, and if they are coming from it, we know that many people with persistent pain, they have other comorbidities and affected in their lifestyle as well, like physical inactivity. And especially from the viewpoint of resistance training. So not many people are engaging on that, unfortunately. So I think it is also a great room to look at it more of a bigger picture of health. And I think this was really nicely summarized by the JP Canero's recent work on the osteoarthritis, and looking at, and I think we can frame that to any sort of musculoskeletal condition. It may be is due to an altered health in general. And one of the components of that may be physical inactivity, and again, maybe meeting aerobic guidelines, but not the resistance training guidelines. And again, we know that if we look at the biopsychosocial model of pain, that there may be still something as a physical cause or a structural cause in a relationship if the person is inactive and they're not currently capable of doing their demands of their daily living that they would need to do. So I think that would be a great segue to use more resistance-based approach, in a sense of saying that these, obviously we have a great health outcomes from these type of treatments or approach, but again, it will help on your situation with dealing with pain. Would you be happy to try lifting or squatting in a different positions, and again put that into the perspective of if they need, say, do gardening. Now I would get them to tell me like what is the position that they would need to be in, and get them to be on those positions and lift through there with a, again, gradually progressive overload. So I think we don't have to try to reinvent the wheel there. We know what in a sense what works in terms of progressive overload is doing more work over time, whether that is through more volume or more intensity. So I would just get them, if that is their goal, to lift something off the ground or push something over the head, it would be just simply as training in close to that context, in whether that was with a barbell or kettlebell or a dumbbell, and gradually progress that too. to that. So I would just use very simple approaches when it comes to progressive overload, but try to put it into their context and what they want to do. But I have to admit that is my bias. So, and I from the other half of the week I work in a gym environment, and the other half in the clinic we have a squat rack and a barbell and a bunch of weights. So that is what I try to get people to do, because with resistance training, there's just something about it. If you get people who are fearful of moving to get progressively lifting heavier and heavier weights, what it does to your self-confidence and self-efficacy to manage activities of daily living, I think that it just works wonders. And it gives you the, like you said earlier, it gives you the other health benefits that many other forms of, say, treatment wouldn't necessarily give you.
Just to kind of like almost bring things back too, is we talked about like what is exercise. Of course, using various modes, whether it's like play and stuff, you're going to be loading people. And sometimes that's just going to be a novel stimulus, so it might be enough to create adaptation. It almost sounds like you're using it in this way too. I like to use those as a form of education. So a lot of people think when we're taught, you got to do education and reassurance, it's you sitting down, having a conversation with somebody and saying like, this is what's going on, this is how everything works. But sometimes I think people just goes in one ear and out the other, and that's completely reasonable, right? That's a lot of information to take in. But once you actually start to get them doing things where they're not solely focused on their pain, you incorporate the fun, and they're just kind of forgetting about some of those other little details, that's when they start to realize like, hey, I can do something and actually feel okay doing it, right? You can use that as like a point of entry and start to create that trust and start to educate them that they can do certain movements, right?
So yeah, okay, going back. So I'm glad you brought out the point of using the play as a way to, as a form of educate, because I don't think that, the pain science or education itself is an intervention, and it can draw a lot of confusion and trying to, quote unquote, explain someone's feelings, what they've been felt for years, without knowing much of the context. You've just had their history taken. So trying to, understand what they're going through, it may be, feeling invalidated to the person of just like, let me just tell you what pain is all about. So using those concepts of play can be very useful in confronting their fears or worries or beliefs. And that's exactly where I use it majority of the time. Say that they are fearful of a movement or hesitant to do, and you look through a physical examination, say the classic example of spinal, bending their spine, and you see that they're guarding, bracing their muscles, they're not breathing where they're going through that, they're moving really slow, and you can ask them, so would you mind if we try this type of movement just for a while? And I'd like to see how you get through these type of, I have a couple of drills. Would you be interested in trying them out? And they may say, okay, yeah, sure. Let's try. Cause you may put it as a part of that physical examination. And then I use my phone. So I may film someone. I was like, do you mind if I, just film it and see how you're moving? We can just discuss this afterwards. And then you may pick up a game, something that I love to do with people, with say low back complaints is use like a stick or your hands, kind of like an archery. You're trying to poke them in a different direction, so you get them trying to avoid your hand, or getting like something like a barrier on the ground, and you give them rules to say like, okay, you need to go over this barrier, but I want you to go in a sequence of placing first your hands before you put your legs. So they have to bend over their spine to try to get over that fence or the barrier, and you show them afterwards. They're like, oh, I didn't know that I was able to bend my back that much. Or then you put that drill for say 1 minute of trying to avoid the stick, and they're going through constant repetitions of spinal flexion and bending. And you ask them afterwards, so how did that feel? And they're like, no, it feels fine, no pain. And it's like, did you just realize what you just did there for like 20 reps or more? And you show them, and they're like, okay, hey, this feels encouraging. This doesn't really, again, I don't know how I was able to do that. And I was like, okay, well, you did, and you managed that just fine. I'm really confident that your back is strong and robust, and it can handle loading. Would you be happy to try to load it a little bit further?
Yeah, sorry, I just wanted to interject there. I just wanted to make that point about, do you think our typical ways of assessing movements and like getting them to do a range of motion, flexion versus abduction, is actually that valid then? Because a lot of people will change how they're moving when you're typically trying to measure it, right, versus how you're doing it, and then they get unexpected, oh wow, I didn't realize I could actually do that. So do you think our typical way of assessing motion is that valid in a clinical setting?
Yeah, great question. I still do the very basics. I get them, through lumbar range of motion or shoulder range of motion, and that can give me an idea of how they're actually doing it. But that may not be the way that they are doing that in real life. They may be, okay, this is a clinical setting, so I'm going to have to do it in this manner. Something that I love to just do in front of a patient is just throw a pen on the floor and show me how you lift that, and see what they do there. So they may say like, okay, I got trouble bending in my spine and that hurts and I can't do it. And if they just lift it with a bent back, it's like, okay, so you just did it right there. You just notice. Or then if they are really rigid and straight back and lifting with the legs and squatting, I can then ask, okay, so why did you do that? And is that where you're having these troubles? And then you can, okay, this is what we will have to work on, and then use, but I may use those at the starting point just to get a little bit of a basic and a framework of understanding how they're moving. But I know that they may be moving completely different in that environment as how they move in a real life situation. So I really like to try to distract them, and odds are that you're actually going to get them moving the way that they don't move. And that's again great opportunity if you have a mirror in front of you or a video that you can do. It opens up a really great room for discussion. I found those type of freestyle movements that you would try to put in the context of everyday life being a lot more valuable than those simple static just stand on there and move your shoulders or flex your lumbar spine. But that's not to say that I don't do them. But something I've gone from physical examination away, which is from rigid, in school, you've had this long list of, orthopedic tests that you had to complete. Through treatment number 5, you'd had to complete all these tests and you had to do all the motion palpation, everything. So there's a very selected amount of quote unquote special tests that I do, if I do at all, or palpation, or I still, do palpate, but again, looking more, tissue sensitivity and any abnormal, patterns of breathing or tensing or guarding or protecting. Again, a nice way to actually just look at the person, say, I heard here. So you just go and touch them and try to, reassure and validate them. So on those reasons, I use them very selectively. So my approach has changed so much through school, which is again, like, it's liberating that you can have all these, you don't have to complete all these tests before you can start managing someone. So it was a struggle in school and try to get away through that sort of rigid framework.
I just kind of wanted to turn the topic a little bit. Something that we often hear, there's almost like if you don't have enough years of clinical experience, maybe what you have to say is not of value. And I respect the information that some of these older clinicians have, that experience, as long as they're evolving. So someone like Craig Liebenson is a great example of that, right? He's got years of practice and he's constantly moving on and trying new things, which is fantastic. But from our previous shorter conversations, I've really enjoyed how transparent you've been, and you talk about your failures. You talk about, I've made these mistakes and I've lost patients because of it, or, I really appreciate that. And I think there's a really good potential for someone like yourself to be able to get a good message across to current students, right? In school, we're often presented from a lot of tutors and teachers all of the success stories. And so we think as soon as we come out, it's just going to be all rainbows and unicorns, and you're only going to be getting people better and changing lives. But do you have any recommendations or just any advice to a student who's like a third-year chiropractic student or a physio student or whatever? Do you have any advice for them, to kind of prepare them for the real world and maybe some resources that they could look into? I know that was a really long question, but I think there's a good opportunity for you to help educate some of the younger folks out there.
Yeah, because once you graduate, you have all these, you feel like a superhero. You have a code behind you, and you're just ready to put your magic in people. That's exactly what I was, expecting once I graduated. But it was definitely a lot more gray area once I got into starting private practice. So again, I think it's about being, certain thing that I think we all learn through university is being able to critically think and evaluate what we're being taught, and being able to actually question those things for real, and not just accept the fact, because I think many people are just uncertain what to do, and they're just like, okay, I've been just taught in this model, and I'm not sure if this is the way, but I'm just going to still stuck in this, and you see that they're not evolving in their practice for years and years and years, and get stuck in the same model. But I personally just noticed that like very soon it just doesn't make sense to me, and it doesn't seem to make a lot of sense to the patients either, or they're just not, I'm not seeing those the outcomes that I'm expecting to see, and that can be quite haunting in a sense, that when the uncertainty hits you, and especially in that time where I felt the need to go through loads of these different courses and learn all the new techniques and everything, and I would argue that you don't. Like I was being always told in my final years, I like, go to as many courses as you can, especially after you graduate, and you need to learn all these technique things. And that can be as well, like really like, okay, how do I get the money to enter all these courses, and how can I learn all of this stuff? But I don't really think that you need any of those courses at all. It is something that I've used really powerfully, is not to, be afraid of making those mistakes, and then self-reflecting back why the patient didn't understand what I was trying to say, or get the response to the treatment. So I think self-reflecting back on that is really a great tool, and I think just constant education and learning. But some people may go through uni and they're like, okay, I've done all this reading and I don't need to do it anymore. as we know, that's definitely not the case. It's just trying to read and learn as much as you can, and not be afraid of trying different things. Have to kind of something that Luke Davies was telling a lot to me as well. You just got to problem solve with individuals. You don't know, you may have a rigid plan. That's why the self-linear model doesn't work, because you may plan ahead everything that you want to do, but the patient comes in with a totally different complaint. They're like, okay, I've got a flare up of another problem, or I can't do these things now. And what can you do then if your pre-planned program doesn't work for that individual, and then you're kind of left out? So I think probably the biggest tip that I probably say that I've learned this year is indeed trying to forget about that you are needing to find the problem solving to everyone, and then have this rigid linear approach, and actually just listening to the patient, because they will probably tell you what is in their life that is missing from there, and work through there with the action plan together.
Yeah, I think you said that pretty much perfectly. One thing that really sticks out to me is what you were saying there is, we talk about trial and error a lot, but it's really a lot more framed as trial and adjustment, right? It's not an error. You learn from it, right? It's how and this is what this whole conversation is about, is how do we shape things, like the importance of the language that you use that Mike pointed out. But I really like trial and adjustment over trial and error. I think that really shows, not adjustment as in the manipulation. Let's make that clear. Trial and reshaping what we can possibly provide to someone. So Perttu, thank you so much. This was awesome. I know I had a ton of fun. I have 9,000 things that I want to reflect on from this. So this is great. Yeah. Where can people find you on social media so they can get your deliciously talented content that we all love to enjoy?
I'm pretty sure you meant the actual, the realigning of the bones and restore the innate intelligence and all that. Where can people find me? Most active on Instagram, so that's where I put most of my content. And that is just at I know my name is difficult for everyone to get so much, crap out of that for myself, and people just have, give up. They're just calling me either my first name or the letter P, or they just call me Finland or any version of that. So, but yeah, Instagram is where I'm at, with just my name, Perttu Riipinen.
We'll make sure we'll put a link to that. No, we are appropriate, and we make conscious efforts to pronounce every name as accurately as we can. We just can't use that appropriate accent because we're too Canadian. We'll try our best, though.
Yeah, you've all done the great job on that name pronunciation. I have to give you that. So it's great.
I'm gonna butcher your name, but in my soap notes, every time I do a test where it's flexion forward, I'm gonna throw a pen on the floor, and I'm gonna record it as the Perttu pen test from now on.
I like that, but I really respect what you guys are doing. Been reading your articles at the ARME website and listening to the previous episodes, and obviously interacting with all you guys individually or through social media. So thank you for you guys as well for all the work that you're doing. Really appreciate it. And thanks for having me. Really enjoyed this conversation. I was looking forward to it for a long time.